Thank you very much, Pam. So I'm sure there are a lot of questions, but as I said, we'll save the questions at the end. So we'll go to our next speaker, Dr. Melanie Prusakowski from Carilion Clinic and Virginia Tech Carilion School of Medicine, Department of Emergency Medicine and Pediatrics.
Thank you. Okay, so while I maybe take a little bit of, have a little bit to say about not all humans being rats, for the most part, I was incredibly impressed. So what we are going to do is talk a little bit about ringing the bell on getting your bell rung. And we're going to listen for the bell as a way of telling us when, this won't advance, telling us when there's something that I'd really like you to know. As members of the community who are here to edify yourselves, I'm going to use this opportunity to tell you all the things I wish more people in the community knew, especially if they have to present to an emergency department. And so there will be a little bit of a bell. I tried to learn something too during Brain Week, so I'm learning how to use audio. Traumatic brain injury, you heard very effectively, is injury that comes from a blow or penetrating injury, and it happens to the brain tissue or parenchyma. That injury happens in a very brief moment, and then there are lots of changes that take place afterwards. Some of my job is that if you present to an emergency department with a brain injury, I look to see what I can do to slow the cascade of secondary events or prevent certain situations like low oxygen levels or low sugar levels that can lead to even further brain damage in the setting of an injury. So here's the first bell. The most important thing you need to know about traumatic brain injury is don't have one. Okay, there are a lot of injuries we just can't undo. The good news is that most of our talk today will be about mild traumatic brain injury and how we care for it, but protect yourself. Okay, who's at the highest risk? Children up to the age of 4 or so, especially young infants. In fact, infants are at highest risk of falls. They are also, unfortunately, at highest risk of being injured intentionally. Then we see a jump to the older adolescent range, and that is really driven by the fact that those children are driving and the injuries that occur as a result of motor vehicle accidents. And then finally, whether breakdancing or not, the over 65 population is at risk for falls as well. And so this is where the types of prevention like night lights and zero entry baths and showers really make a difference. Okay, so what are we talking about? This is an injury that I think you don't need to be a doctor to diagnose, right? There's a break in the bone, the calivarium, the break in the skull, and it can be minor, like on your left, or it can be something that intrudes into the brain tissue, as on the right, which of course makes it much more devastating. When we talk about a bruise to the brain or a contusion, you can see these areas of kind of white in the right upper corner there. That is where the brain tissue has bleeding within the parenchyma and is now at risk of swelling. Then there are the types of hematomas that you might hear about, the subdural and epidural hematomas. So on the right, we have an epidural hematoma. You see that lenticular collection of blood that shows up as white that is now putting pressure on the brain tissue. On the left side, there's a more subtle kind of collection. This is subdural, but it's been enough blood collection to push these midline structures to the right. And you see this open space here called a ventricle that's been completely effaced because of the bleeding and the pressure. And so we start to see very significant symptoms and dysfunction when you have bleeds like this. So this brings us to one of my bell moments. If you are someone who is on blood thinners because you have atrial fibrillation, you've had a DVT, deep vein thrombosis before, or someone you love takes blood thinners, even mild head injuries need to be assessed by a caregiver. Blood thinners put you at particularly high risk for the types of hematomas that we saw, those epidural and subdural hematomas, and so you need to be checked out. What other symptoms might need to be checked out, even if you're not on blood thinners? Well, Definitely if you have a fracture or you think your face or skull is fractured, please make sure you get seen. Additionally, if you have bloody or clear fluid draining from the nose or the ears, that's something that can signify a fracture that you can't see. If you're having any type of seizure activity. Now, believe it or not, kids sometimes do have impact seizures, and we're finding it may not influence their risk of having a serious traumatic brain injury as much as we once thought, but regardless, they need to be examined. The next three symptoms there are sort of signs of change in neurological function. So a droop in the face, slurring of the speech, feeling like you can't move one of your limbs, or having a loss of consciousness or feeling lightheaded. All of these would be reasons that you need to be assessed, especially if after a head injury. Anytime there's an alteration of breathing, that needs to be assessed. Similarly, a stiff neck could signify one of those blood collections that we call a subdural hematoma. Lots and lots of people who fall and hit their heads have headaches and vomiting, okay? But if you're having persistent vomiting or a severe headache that's not responding to some Tylenol or Motrin, then it definitely needs to be evaluated. Now, we are using information and data from a large conglomeration of researchers called the Pediatric Emergency Care Research Network. And one of the things that they've done is looked at over 44,000 children. And they have proven now something that just felt like Gestalt to me when I was kind of learning to be a pediatric emergency physician, which is kids who come in and have hit, and who are 3 to 1 year old, no matter what they've hit, they're vomiting. They have a head injury, they vomit in my emergency department. They stub their toe, they vomit in my department. They have a broken arm, they vomit in my department. And so I was always wondering, you know, why do we make such a big deal about the vomiting? The Pediatric Emergency Care Applied Research Network proved that those children under 2 in particular swallow a lot of air when they injure themselves, and so vomiting is not associated with an increased likelihood of having a traumatic brain injury. This is the kind of information that's really changed how we manage some of the patients that come into the emergency department. Sometimes, and especially in patients who are pre-verbal because they're too young or because they have a developmental abnormality, irritability or clumsiness or restlessness may be the only signs that a head injury is serious. So those are also symptoms we want to pay attention to. But most importantly, anytime you think a symptom is worsening in the setting of a head injury, especially if it was something that seemed to go away and has now returned, please make sure that it's assessed by a caregiver. But as Dr. Van de Voort told you, about 75% of the head injuries that present to the emergency department will be mild traumatic brain injury or concussion. And that CT scan right there looks perfectly normal because as she described to you, you can have a lot of symptoms, a lot of dysfunction, and still have a normal CT scan, which is our really standard of care for assessing somebody with a head injury. It's important to know that you don't have to hit your head to have a concussion. It can be transmitted energy from a blow to your body. And I think this is probably very easy for you to understand after seeing Dr. Van de Voort's lecture. So it's a functional, not structural injury, and as a result, we're going to diagnose your concussion based on your symptoms and your examination. So so-called getting your bell rung is really a traumatic brain injury. What happens is, because of a mechanical injury, there's an abrupt depolarization of your nerve cells called neurons, and they release the proteins that they use to communicate with each other, neurotransmitters. As a result, a lot of different types of inflammation can occur. It changes how the brain cells, those neurons, use oxygen. It changes how they use sugar. And essentially, the brain goes into a kind of an energy crisis. It can last for about 7 to 10 days, and as a result, you may continue to develop symptoms over 7 to 10 days. So when you're seen by a caregiver, you might not have the only symptoms that are going to develop. And that is the reason why a lot of times when you're seen in the emergency department, they'll ask you to make sure you follow up or return if new symptoms develop. It's also the reason why if you're pulled away from your activity, you were in a rodeo, you were in a soccer game, you were playing rough, and you have to be assessed for a possible head injury, you should not return to play immediately. You should be assessed to make sure that further symptoms aren't going to develop because you may have a concussion. Okay, so concussion is a traumatic brain injury and it's affecting the function of the brain. What types of symptoms do I see and associate with concussion on a regular basis? The concussion and the confusion and kind of feeling foggy, trouble concentrating and remembering, that is not at all uncommon after a concussion. And it's one of the things that I make sure patients expect and families expect, because this affects how children can perform in school, how adults can perform at work, and it's something that they need to know about as they return to those activities. Okay, then the headache. And this is a tough one because you can have a lot of headache after a concussion, and how much is too much? Nobody really knows that. But again, I try to drive home the fact that if you're treating your headache with some Tylenol or Motrin and that's kind of keeping it manageable for you and your headache isn't getting increasingly severe, then that is probably within the realm of what's to be expected after you've had your bell rung. This sensitivity to light or noise is the kind of thing that you can do a lot to really help somebody in their concussion recovery by minimizing loud noises and kind of craziness in the home. And then we're learning more and more about how the effects of a concussion really can affect your behavior and your mental health, the anxiety and the depression that Dr. Vandevort discussed. Okay, so we're trying to be heads up when people come in, especially to our pediatric emergency department. But here's something I see, several times a week. All right, an adorable, awake child with a giant goose egg. And I think it's really, really easy to see why families are concerned when this shows up, right? I hear a lot about, well, I'm glad it swelled out instead of swelled in. So that's not usually something we worry about because what we are trying to decide is if there's a skull fracture underneath there. What I will tell you is one of the reasons that child has such beautiful supple skin is because of his beautiful blood supply. And so that bleeding there is one of the reasons that will heal pretty quickly. It's also the reason that if he had scratched it, it would have bled and bled and bled and it would have looked like a bloodbath by the time they got to me. But the good news is we have information from the pediatric network about how important it is to watch for hematomas and the fact that a hematoma on your frontal bone, which is your forehead, does not increase your risk of having one of those brain bleeds we looked at the beginning of the lecture. So this child, if he has headache or is a little bit unbalanced, this child has a concussion, not one of those more significant bleeds. Okay, so we talked about PCARN. All right, so now let's talk about one of the other things that comes into our emergency department, both adults and children, sports injuries. Okay, and this has been a really hot topic as concussions among pro athletes has garnered more and more kind of discussion. So we see a lot of TBIs related to sports, and about 1 in 5 concussions are sports related, but only 1 in 10 require hospitalization. They say that a college football player has a 40% chance of having a concussion each year that he plays. A lot of the most significant concussions seen in the pediatric age that are sports related are actually related to soccer. 2 people going to head the ball at the same time who collide together, and also from heading. And so a lot of rules to reduce or increase the age at which you can start heading has contributed to a smaller number of concussions. The other thing is, the highest number of pediatric concussions comes from soccer because in this country, the largest number of children play soccer. So that makes sense. Equestrian sports, which I see a lot more of here than when I worked at the Children's Hospital of Philadelphia. And there can be some serious injuries, although the good thing is helmets are usually required at least in competition. Skiing. Again, helmet rules or just kind of people using helmets when they ski has helped a lot. Baseball. Baseball doesn't result in a lot of head injuries, but the ones that happen can be serious because they're usually happening because of being hit with a ball or a bat. And then in Canada, of course, all the children, the greatest majority of children who have head injuries come from hockey. But then don't forget about some other really serious modalities. I see a lot of traumatic injuries from ATV use in children and in adults. And then things like cycling, skateboarding, all can be done more safely with helmets. So I love this picture because this strapping kid is clearly suffering on the sideline, and yet when that child shows up in my department and says he has a headache and maybe even a little bit of nausea, and he just, you know, seems slowed, and the parents say he's not answering my questions the way he normally does, his CT scan is going to be normal. His CT scan was normal. And yet he is clearly having distress. So this is what concussion can look like. So we're basing the discussion on, we're basing the diagnosis on our history and physical exam right now, but the time may be coming that we'll be using modalities like those being used in research here at the Fralin Biomedical Research Institute, functional MRI. That's instead of just looking at what does the tissue look like, we will look at how is that tissue using oxygen, or how is that tissue using sugar right now, and be able to tell that there's an area where the function has been impaired. Okay, so one of the things I hope I've instilled upon you is the idea that a physician can diagnose a concussion without a CT scan, and choosing not to do a CT scan and sparing either you or a loved one some radiation doesn't mean that they don't think this is a serious head injury. They just think it's one where they're not going to get more information from the CT scanner. And a full neurologic exam and observation is an important part of being assessed. Don't say, well, if they're not going to do a CT scan anyway, I'll just watch them at home. There are some subtle things that we can pick up on and that we need to watch for. I think that a huge part of my job is educating families who have children who are involved in sports, coaches. I speak with the athletic directors of the schools in the region, and we have done a lot. This has been an incredibly receptive community towards trying to reduce head injuries by not having bull in the ring and full contact practices in some sports, and reducing the number of times that you put a JV team against a varsity team to practice together, and just trying to have people matched up a little bit more by skill. So we want people who have suffered an injury to not forget forever that they're on the Cubs, just for that one glorious moment. Okay, so now let's say you or somebody you know has suffered a concussion. What can you do to recover from it? Your brain is temporarily having dysfunction. How do you help it to regain that function? I like to describe my instructions into physical rest and cognitive rest. Physical rest means not doing a bunch of extra exercise, not staying up late, taking naps when your brain feels tired. Cognitive rest means if you don't already know how to play chess, this isn't the week to learn it. You know, it does mean that children might need to stay out of school. Some adults may need to take some time off from work, or maybe you can only do a half day. It may mean that if you come home from school, you have to take a nap before you do your homework. Sometimes I write notes so that people can have tests moved. And actually, I have the benefit of having a really good neuropsychologist here who helps me in cases where I think people really may be suffering for some time. They can provide the type of neuropsychological testing that determines when somebody should go back to school, when somebody should be able to take the ACTs or the SATs because it's that time of year, and helps me get my very competitive athletes who are in season and potentially being scouted back onto the field as soon as possible, but when it's safe as well. So I run into a lot of people who come in and really aren't feeling well and just don't seem to be getting better as quickly as I think they should. And then when I tell them, you know, now that you've been feeling this way for so long, I'm afraid you have a concussion, so we're going to have to make sure you don't text for the next several days. And immediately they can like jump up, and, you know. So a lot of it is just giving people the right, I think, incentive as well. So what happens if you do some of these things while you have your concussion? You won't injure your brain any further, but you could prolong how long you have symptoms. And so that's why this rest, both physical and cognitive, is so important. I also tell families, in particular when children are young, to watch out for kind of frustration, memory problems, being more emotionally labile. So more quick to get frustrated, more quick to get angry for something that's seemingly unimportant. And it's usually around that time that my parents of adolescents are like, oh my God, well, he's had a concussion since he was 12 then. But the truth is, these are some of those insidious symptoms that make people feel like they're not well, but are hard to really put a finger on. And then in terms of getting my athletes back to play when the injury has occurred because of, even if it hasn't occurred during your sport, getting you back to your sport or activity, I tell people that they have to have at least 5 days in a row of no symptoms. And that's really to make sure that you've given the brain ample rest. The reason is because if you re-injure the brain while you're recovering from concussion, then one of the major functions that's affected is the brain's ability to protect itself. And so while you'll only prolong your symptoms if you do too much texting or watch too many movies, you can really put yourself at risk if you injure your brain again. So recovery can continue for a long time, although for mild concussions, and we don't have a classic grading scale for them that we use anymore, but for the concussion where you're symptomatic but we expect you to recover in a day or two, we really do expect that to be a relatively short recovery. What we have found that the recovery from concussion can be really complicated by children who have underlying either psychiatric disease, they have a little bit of anxiety or depression to begin with, they take ADHD medication because they have ADHD, or because they've had prior concussions. So those are things that can really complicate your recovery. So just to kind of summarize, a management of concussion is being evaluated and watching for those worrisome signs and symptoms like worsening symptoms or changes in your neurologic status. Resting early and then gradually returning back to activity to help with recovery, and then avoiding re-injury. Because what we're trying to make sure doesn't happen is something called second impact syndrome. And there are just some devastating stories of these, you know, children and girls and boys who are athletes who look like they're chiseled from stone and look like they're indestructible, who, you know, come out and look a little dazed and sit at the sideline and then get put back into a game, get another kind of relatively mild injury, and have to learn to walk again or lose their lives, because what has happened is the autoregulatory systems have been affected by the concussion, and so there's vascular congestion and swelling that no doctor can slow down, and they just don't even make it to the emergency department most of the time. So the most important step in recovering from concussion is not getting re-injured. No roughhousing with your brother, taking it easy from your skateboard. If you're a cyclist, not, you know, maybe taking a few days off and making sure that you're not on rugged terrain where you can be hit by a car, those types of things. And then and I focus a lot of what I do when I send people home on really helping them understand the fact that it's going to be a little bit of a process, and then we expect you to get back to your activity in full form, ready to play, ready to compete. And this is kind of what it looks like. It's a step-by-step. After 5 days of not having symptoms, you then can do a little bit of light exercise, and if you don't have increased symptoms, you start doing some drills where you don't have contact, a more sport-specific drill, and eventually get back to full play. So Dr. Vandevort told you that about 20% of people who undergo a concussion actually do have symptoms for a prolonged period of time, and we call that post-concussion syndrome. And what we're also learning is that even if you've had a mild concussion, if you've had more than one, there can be some really serious effects that result. There are some degenerative changes in the development of a protein called tau protein that contributes to something that's now been called chronic traumatic encephalopathy. And it's come to everyone's attention because it's a disorder, a dysfunction that's showing up in the retirement years of pro athletes like boxers and football players. So this is a very pretty example of a magnetic resonance spectroscopy. So it's looking at two specific proteins, N-acetyl aspartate and choline, and the ratio of those different proteins. And so here is what is a control subject, believed to be a healthy brain. And then we see some of the changes related to scarring and tau protein deposition that changes the N-acetyl aspartate or the NAA and choline in the brain. And then here you see some areas where the choline levels are particularly high, shown as red in a football player who has had a few concussions. And then this is a blast injury victim, military brain, like that described by Dr. Vandevort, showing that there are some similarities, but they're not exactly the same. Different kind of scarring that happens in general. And then this is a tissue specimen showing the extent of the degeneration that can happen when you really do have multiple concussions. The laying down of that tau protein, which prevents healthy tissue from proliferating. So that's chronic traumatic encephalopathy. What we're also finding is that there are some correlations between the number of concussions, especially severe concussions that someone has, and the likelihood that they are depressed. And of course, the concern is always that the number of concussions recorded is probably much lower than the actual number. A lot of times, unfortunately, people are motivated to underrepresent the fact that they may have had a concussion or the symptoms that they're experiencing. So concussions have cumulative effects. We no longer want to call getting your bell rung inconsequential. So as a summary, I'm just going to go through some of the bell-worthy bits of information. Prevention is the only cure. A head injury can't be undone. Seat belts, helmets, these things really save lives, and fall prevention around the house makes a difference. If you're on blood thinners, you always need an evaluation after a head injury. They increase the risk of bleeds that can be of real consequence, and make sure your doctor knows about your medications. A concussion is a traumatic brain injury that affects the brain function. It can happen after a blow even to the body, not just the brain, and it is a traumatic brain injury. Your doctor can diagnose a CT scan, concussion without a CT scan, but victims do need a full assessment if you're going to forego that CT scan, and usually some observation. The most important step in recovery is avoiding another head injury. No same-day return to play in someone who has concussive symptoms. And concussions have cumulative effects. Getting your bell rung is not inconsequential. It's a traumatic brain injury, and especially there are consequences to multiple concussions. Thank you very much.
Thank you very much, Dr. Prusakowski. So now if both Dr. Vandevort and Dr. Prusakowski would come back up, we'll open the floor to questions to either or both of you. So I'd like to ask everybody, as in previous nights, to please stand up so everybody can hear your question a little bit better. We'll start with you right here. Go ahead.
Hi. So my interpretation of what you're saying is that a physical injury, such as a mild TBI, could easily be diagnosed as a psychological problem. And I'm wondering what research like yours has on the implications for treatment of something like PTSD.
So I think Dr. Vandevort's data really suggests that we see behavioral changes after some types of blast injury. And so they are purporting that there's a true traumatic brain injury that it could then be tied directly to behavioral changes. The data that shows the types of mental health changes in concussion are actually twofold. So one is that there are findings, correlations between people who already had existing depression or anxiety and difficulty recovering from concussions, more prolonged recovery. And then the second is we're seeing that especially in people who have sustained multiple head injuries, they are more likely than their non-injured counterparts to eventually be diagnosed with depression or anxiety. So I didn't show you that exact data, but those findings seem to be particularly strong in very young children who sustain significant concussions. We're talking about like the young school age 5 and under.
Back there, please stand up.
Yeah, just a quick question. There's a lot of people that are on AFib drugs, Xarelto, Coumadin. That clearly is a blood thinner. Does aspirin qualify as a blood thinner? Do you show the same respect for a head injury if you're on aspirin?
So yes, aspirin, high-dose aspirin in particular, the daily baby aspirin dose has not been shown to significantly increase your risk. But the risks of aspirin are one of the reasons why things like Xarelto have been developed. And so we're constantly trying to keep people anticoagulated to protect their health and not increase their risk of the everyday bumps and bruises at the same time.
Yes, sir.
In the military analysis, how close are you to the actual serviceman and his or her experience and what you're doing in the lab with the glass device, smaller control? Do you have any good data to apply to what you're seeing in the lab?
Yeah, that's a really good question. So we work a lot with the Army, except for they don't specifically tell us what pressures these guys are seeing in the field. They kind of hide that. It's all classified. There's a lot of research going on right now where they're requiring a lot of the military personnel to wear sensors, pressure sensors, so they can gather that data to try to feed it to us. The individuals that we talk to feel like our model is very relevant to somebody who is what we call in the far field. So again, they're not close enough to the explosion to have the thermal or chemical effects, but they still get exposed to this overall pressure. So we're really comfortable that we're modeling the military event that they think a large proportion of the soldiers are undergoing.
Is your lab working on a biomarker? Maybe blood, serum, CSF, anything like that?
Me? Yes, yeah. So we are. We actually collaborate with the University of Florida, who has a big blood biomarker bank there. And we do collect blood for our animals, and we send it there, and they're looking at some of the markers that some of them are coming out, like GFAP is one of the ones that's coming out in the clinics now, but it's mostly targeted for more severe types, right? Some of the mild, the levels are still a little unpredictable, but we are working with individuals that are focused on that.
For Dr. Vandenborg, you mentioned that the potential therapeutics for TBI have only been effective in a small proportion of patients. Is there any speculation as to what would be different between responders and non-responders in that regard?
Is that for me or is that for you?
No, I think it was for you, one of the slides you showed kind of towards the end about with the medicine. I mean, from what I've seen on patient studies, it tends to be more related to severity of the illness and not necessarily other patient characteristics. However, I have not recently reviewed that literature, so I can't give you a for sure answer on that.
Yeah, we're doing some trials with some individuals to try to look at what I mentioned, the antioxidant levels, and trying to target some therapies that might help balance that. But again, we're still in the preclinical trial stages, but I know there's a lot of different, all these molecular pathways that kind of get activated by a mechanical force. There's still a lot of research that needs to go into that to try to identify which ones might be similar, because maybe something that gets triggered in the blast is also in the impact related, and it can help both different types of injuries. But again, we're kind of all in the naive state of that research. And
so what we're left with is our treatment modalities have to be aimed at either treating your symptoms, your nausea, your pain, giving you balance therapy and physical therapy, that type of thing, or they need to be aimed at preventing further injury, like preventing you from having a seizure, or preventing your cerebral perfusion, which is blood flow to the brain, from becoming low enough that in addition to having an energy crisis, you're also poorly perfused, that type of thing. So, but we don't have a good modality in the human realm yet.
In your picture about the healthy brain, the less than healthy brain, so what is the main reason other than the injury? Is it the oxygen? Is it blood flow that makes it a lot worse?
So we're not exactly sure, but we don't believe that it is mostly related to blood flow or mostly related to oxygen, because again, people with mild concussions come in and never have an obvious hypoxia, which is low oxygen situation, or never become hypoglycemic, which is when your blood sugar is too low, and yet especially if they are, and remember, those are samples from people who have repetitive injury, especially if it's happening repeatedly, there is some sort of change. And part of that change is related to that neuromuscular cascade creating a new protein called tau protein, which the way I've kind of thought about it is almost like laying down scar in your brain and then preventing the proliferation, because we don't make we renew synapses, which are connections among our brain cells, and whatever prevents that, so that then when you lose it, it can't be recovered as easily. So we don't know exactly yet, and that's what we're looking for. And if we knew that, then we would create a biomarker to look for it. You've just shaken up your brain, and now we're going to look for whatever protein is elevated in your bloodstream as a result.
Well, if there are no more questions, before we stop, I'm going to...
One more in the
Sorry, where is it?
Yeah.
In the back. Go ahead.
Since infants are the most at risk and they can't really verbalize something in particular is bothering them, and they tend to get irritable about all sorts of things, it's hard to pinpoint exactly what they could be. Is it possible for an infant to suffer from a traumatic brain injury but it go unnoticed? And is there anything later in life that could suggest that they had a traumatic brain injury that went unnoticed?
Okay, so those are great questions. That's part of where the art of medicine comes in. So I'm constantly dealing with this sort of seesaw effect of I don't want to miss an injury, especially someone who's nonverbal and requires care from others, but I also don't want to irradiate developing brain tissue with a CT scan for relatively no reason. Okay, so I'm looking for the times when my clinical suspicion is high enough that it makes it worth the exposure to that radiation. At this point in time, I don't know of anything where a case report of somebody who had something unusual develop in their later childhood, and then they went back and said, okay, looking at your brain, it's clear that you had a traumatic brain injury that was never reported. However, I deal with that possibility of a brain injury as a cause of irritability all the time, and unfortunately a lot of times we do see shaken babies, children who are people get frustrated or and the baby is traumatized, and then there's a bleed in the brain. And actually what is horrifying, I have a picture, horrifying is that sometimes even though you only have a little bit of bleeding on the initial CT scan, which is the one on the left, the change to the brain tissue that happens because a shaken baby might not be brought to the emergency department so that we can prevent seizures and prevent hypoxia and prevent hypoglycemia. And that brain tissue is so fragile and still developing, the new tissue doesn't develop as we would expect during brain growth, and you're left with these dark areas where brain tissue has not developed. And so that, of course, is devastating, and that child is severely affected. Okay.
Again, before we end, firstly, I'm going to make a comment and a question myself. my comment to Dr. Vandervoort. She said at the beginning that we know people are not rats. Well, in political discourse today, we're hearing a little bit of that in the news. So I think, and secondly, I had a question for Dr. Prusakowski. Your very first slide, or one of your first slides, showed the little baby sitting on top of the concrete steps. I presume there was somebody off to the side out of that picture somewhere.
So I pirated that off of the internet, but it's because anybody here who's a parent, I think, knows that they are but by the grace of God, right? Somehow
Right,
they wind
right.
up teetering on the edge of something every so often.
Right. And I did want to add one little bit of science too. Actually, there's a group at Johnson & Johnson and UC San Diego that last year won the World Brain Imaging Prize for their work to be able to visualize tau in the brain of living human beings using a technology called PET, positron emission tomography. Trouble is, there's radiation and it's expensive and it's not routine, but might be helping us with some of these things. And interestingly, tomorrow night's program will follow on very nicely from this, dealing with brain aging and dementia, and touch on some of the very same subjects we heard tonight. And lastly, immediately after this, Dr. Fox will have the human brains outside. So now, without further ado, please join me in thanking both of our guests tonight for tremendous presentations. Okay, folks, go see the brains. Thanks for coming again. That was great, you guys. Both fantastic. Thank you.
I learned a lot. That's really cool. I'm excited to see what